Ni campur dengan male punya juga ke?
Male tak ada tapi ada. Maksudnya tak ada kat sini tapi ada.
Nak.
Boleh try.
Dia bilang kau tadi last minute ni semua benda penting.
Include annotation no, include background yes, and then okay.
Ada male punya tak?
Ni jap cari.
Kawan kau ni fisio pun belum masuk.
Tak apa, nanti pas juga. Yang aku tak tahu kau punya perangai.
Dengan belas esai PBL lah.
Oh.
Kalau PBL tu tak ada ya.
Tekan-tekan untuk jawab CD nanti. Tapi sikit je lelaki punya. Tak sampai 2 page.
Boleh.
Dah. Drop.
Okay, a very good morning. Everybody ready?
Yes.
Okay. In honesty, how many of you guys watched the video? Okay. How many haven't watched the video yet? Me. Okay, cool. Alright. So, doesn't matter. So what I'm going to do is, for male reproductive system, it's very simple. It's very simple. So I probably need around 20 minutes for this lecture. So we're going to go through male reproductive system. Then we're going to do some questions for both female and male reproductive system. So when we do the questions, I'm asking the basic concept, basic knowledge. So when you answer the question, macam not know what are they talking about, never heard about the drug, then you have to go back and study again. Okay? Alright, for drug in male reproductive system, incomplete gender biasness, because male is super simple compared to female. Female are complex creature. So the lecture for male reproductive system, I'm only going to introduce 2 diseases, which is erectile dysfunction, ED, and benign BPH, benign prostatic hyperplasia. Okay? So first of all, this is generic. A pharmacology lecture mesti kena tahu mechanism of action, pharmacokinetic profile, adverse effect, and contraindication. Okay? And male reproductive system, you have to know everything. Do not skip anything because I'm only going to introduce 3 groups. Okay? So first of all, erectile dysfunction. What is erectile dysfunction? Okay, erectile dysfunction is inability to achieve or maintain. Some they boleh erect but cannot maintain. So all under the same category. Inability to achieve or maintain an erection adequate for intercourse. Why does this happen? Because of arterial insufficiency due to maybe trauma, smoking or atherosclerosis, or the hormone itself, androgen hormone is insufficient, or sometimes when it's hyperglycemia, that can also cause ED. Okay? So there's only one group of drug. One group of drug for ED, which is the first-line therapy. Okay? This drug is called phosphodiesterase 5 inhibitors. Okay, example of drugs, sildenafil, tadalafil, all the lafil, vardenafil, avanafil. Okay, anybody knows the famous name for this group of drugs? Viagra, okay? Sildenafil is also known as Viagra. So a little information about Viagra. Initially, Viagra or sildenafil, the research is for cardiovascular system. You want to relax the blood vessel to improve the blood flow. But then they realized it's not only it's not targeting on cardiovascular system, it's actually promoting blood flow into the male reproductive system. Hence, that's why sildenafil is marketed more for erectile dysfunction. Okay? So it's a first-line therapy. The difference between all these drugs, sildenafil, tadalafil, vardenafil, is because of pharmacokinetic profile. Okay? It's nothing got to do with side effects. It's more about when it can reach its Tmax. Okay? So its mechanism is inhibits the inactivation of cGMP. Okay, in a normal process, what happens is when there's a sexual stimulation, there will be a release of nitric oxide. So what does nitric oxide do? Nitric oxide activates guanylate cyclase enzyme that converts GTP to cGMP. The main culprit that you want to know is cGMP. Why? Because cGMP
Doctor.
reduces.
Pointer, doctor. Sorry.
Pointer.
Sorry. Ada. Alright. So the first important thing is release of nitric oxide. So nitric oxide activate guanylate cyclase. Guanylate cyclase will convert GTP to cGMP. So your most important thing over here is cGMP. Why? cGMP reduces the calcium in the smooth muscle. So when you reduce calcium, it causes muscle relaxation, vasodilation, so increased blood flow. How does it reduce calcium? It will increase the storage in the endoplasmic reticulum. It will prevent, the yellow color here is inhibition. It will prevent the uptake of calcium. So there will be a decrease in calcium as net. Increased storage of calcium, reduced uptake of calcium, all this will reduce calcium in the smooth muscle. So the smooth muscle will relax. When the smooth muscle relax, increased blood flow. When there is increased blood flow, it will stimulate erection. Okay, so this is normal physiological process. Okay, now the person over here has an issue. It cannot achieve or maintain erection. So we want to help them. How we want to help them? We want to make sure there's high level of cGMP. So we will block PD, phosphodiesterase 5. What does phosphodiesterase 5 enzyme does? It will inactivate cGMP to 5' GMP. Because obviously, once in normal physiological process, when there is an erection happen, the erection should stop. It cannot be maintained erection throughout. So how does it stop? When cGMP is being inactivated. Okay, how do you inactivate cGMP? Phosphodiesterase 5 enzyme. So sildenafil, what does it do is, it inhibits this enzyme. Once you inhibit the enzyme, so you have high concentration of cGMP. When you have high concentration of cGMP, so you will promote blood flow. So that's how you achieve erection. Okay? Alright, so here, as I mentioned, all the drug is similar. The difference is the pharmacokinetic profile. For example, sildenafil, vardenafil, Tmax day 60 minutes, but half-life day differ. Like if you look at tadalafil, Tmax day 2 hours, but half-life day 18 hours. Okay? So the difference is when do you use it? Do you use for long term or do you use as necessary? Okay? But the adverse effect, headache, flushing, dyspepsia, nasal congestion, cardiac risk, because this drug initially is for cardiovascular system, so your side effect will also be on cardiac risk and visual disturbance. Okay, drug-drug interaction. Phosphodiesterase 5 inhibitors contraindicated in patient taking organic nitrates. Because when you have organic nitrates, your NO increases, then your cGMP pun increases, so it can lead to adverse effect. Okay, and as well as alpha-adrenergic antagonists. Phosphodiesterase 5 inhibitors are metabolized by CYP3A4, so it is contraindicated when you co-administer together with CYP3A4 inhibitors. So what happens? I baru je lepas lecture year 1. So what happens when you co-administer with the CYP3A4 inhibitors? Phosphodiesterase level in the body increase ke decrease? Decrease?
Increase.
increased because they inhibit the metabolism of the drug, right? So when you have increased level of this drug in the body, so there's a high chances of adverse effect. Okay? That is all for erectile dysfunction. Only one group of drug. Okay? Phosphodiesterase 5 inhibitors. Then we move on to benign prostatic hyperplasia. Okay? Benign BPH, it's non-cancerous. Usually, very commonly, when the patient comes, you see enlarged prostate. Okay? That presses against urethra. So because it presses against urethra, all your symptoms will be the urinary symptoms. For example, voiding symptoms. For example, polyuria, nocturia, difficult starting urination, weak urine stream, dribbling, and inability to completely empty the bladder. Okay? These are the common symptoms of BPH. So you have two groups of drug. Number one is alpha-1 adrenergic antagonist, or your Zosyn. It's an antagonist. Alpha-1 physiologically causes vasoconstriction. So if you antagonize, it causes vasodilation. Okay? Example, all your Zosyn. Terazosin, doxazosin, tamsulosin. Selective competitive alpha blockers. So what does it do? It relaxes the smooth muscle, because just now you have voiding symptoms, reduce in incomplete emptying of the bladder. So when you relax the prostatic smooth muscle, it will improve the urine flow. You have better emptying bladder. Okay? So for alpha-1 adrenergic antagonist, it's important for you to know which group of drugs that actually acts on alpha-1A, which is on smooth muscle, and alpha-1B, which is smooth muscle and vessels. Okay? Why? Because BPH is commonly among elderly, and elderly usually are the hypertension issue. So when they take antihypertensive drug and you prescribe alpha-1 adrenergic antagonist, so if you prescribe doxazosin, it acts both on smooth muscle and blood vessels, you will observe decrease in BP. And if the patient is taking another antihypertensive drug, it will further reduce the BP. So you might want to consider tamsulosin or silodosin, where it acts on alpha-1A only, which is on smooth muscle alone. So you don't see much of a difference in blood pressure. Okay? So for alpha-1, just now for phosphodiesterase 5 inhibitors, is the pharmacokinetic profile. The different time is required to achieve Tmax. For alpha-1 adrenergic antagonist, it's the effect, whether there is an effect on blood pressure or not. Okay? So pharmacokinetic profile, Tmax usually in 4 hours, half-life is very long, metabolized by CP450, adverse effect, dizziness, nasal congestion, lack of energy, headache, drowsiness. As you can see, adverse effect is not really bad. It's all more of inconvenience rather than life-threatening. Whereas phosphodiesterase 5 inhibitors, it's more about cardiac risk, life-threatening. Okay? So besides alpha-1 adrenergic antagonist, Alright, alpha-1 adrenergic antagonist for drug interaction, okay, it is metabolized by CYP3A4 and also 2D6. So you have to be careful when the patient is taking verapamil diltiazem, because verapamil diltiazem are CYP3A4 2D6 inhibitors. Okay, why am I highlighting this kind of drugs? Because BPH is common among elderly. So you would see patient taking verapamil because of their hypertension, or maybe because cardiac arrhythmia. So it's common these drugs are being prescribed. So when the patient has BPH as well, you have to bear in mind drug-drug interaction. Okay? So alpha-zosin may prolong QT interval that can also cause ventricular arrhythmia. So you need to make sure that what's your patient in your cardiovascular symptoms like. Okay? So that's the first group of drug, alpha-1 adrenergic antagonist, competitive antagonist. And you need to know the main function of this drug, it promotes the urine flow because you have voiding symptoms, voiding difficulty. So when you prescribe this drug, the empty bladder, characteristic of emptying bladder will be better in this patient. Whereas the second group of drug, 5 alpha reductase inhibitors, all your steroid, finasteride, dutasteride, it provides relief symptoms but longer, 7 to 10 days. But it is best used in combination of alpha adrenergic antagonists. But here, it's nothing got to do with the blood vessel. It's more about the androgen hormone. So it inhibits the conversion of testosterone to more active dihydrotestosterone. So it reduces the androgen hormone. So how does it do? Okay, first of all, testosterone enters the cell, and then it will be converted into dihydrotestosterone, because dihydrotestosterone that will bind to the androgen receptor. Because it's a nuclear drug, so it will promote the transcription of growth factors. That is the normal physiological process. So 5-alpha reductase inhibitor, it will inhibit this enzyme. So it will prevent the conversion of testosterone to dihydrotestosterone. So you don't have dihydrotestosterone, it cannot bind to the androgen receptor, there will be no transcription of growth factors. So what you would see is not only, you won't see much of the urine flow because BPH can enlargement of the prostate. So because your androgen hormone is low, you can reduce the size of the prostate. Whereas your alpha-1 antagonist improve the urine flow can. For 5-alpha reductase inhibitor, it will reduce the prostate size. Okay? So pharmacokinetic profile, it is highly bound to protein. That's why you would see the effect 7 to 10 days. It's a very long time in the body. Plasma elimination rate 6 to 16 hours, steady state for 6 months. Okay? If you see this kind of pharmacokinetic profile, you know this drug is highly bound to protein. Okay? Adverse effect, because it plays around with your androgen hormone, so you will have sexual side effects. For example, decreased libido, erectile dysfunction, gynecomastia, oligospermia, and other teratogenic effect. What do you understand by teratogenic? What does teratogenic means?
Baby, this one.
Effect on?
Baby, fetus.
Effect on babies. Okay? Because when you have oligospermia, you have your sperm is is not fully functional. So the baby that is produced might be a bit defect because you are actually disturbing the synthesis of the hormone, androgen hormone. Okay? So this will be my last slide. So if you want to compare these two group of drug for BPH, alpha-1 adrenergic antagonist, it does not give any effect on the prostate size. It's more on improving the urine flow. Whereas 5-alpha reductase inhibitors, yes, it reduces the prostate size. Why? Because it will inhibit the androgen hormone. Okay? Peak onset, 2 to 6 weeks, faster. Whereas 5-alpha reductase inhibitor, takes longer. Sexual dysfunction, you don't see much in alpha-1 adrenergic antagonist, but you'll see in 5-alpha reductase inhibitors. But hypotensive effect, it's more on alpha-1 adrenergic antagonist, but not so on 5-alpha reductase inhibitors. Okay, any questions? Okay, now we quickly go through the questions. The quiz. Okay, what I'm going to do is, if you cannot answer the question, just try. We'll go one by one, and then we'll try to understand where's the confusion all about. Okay? Kejap ya.
Lekasnya apa?
Filming.
Ini?
Dia kata tak mau quiz. So, physio. Last physio. This is
Sebab tak ada orang kan? You talk too soon, doctor.
Tak sistem lah.
Sistem. Afif, last time your ECA class pass.
Okay guys, get ready. Okay, we can take this as an attendance. So I would know how many of you guys attended today. So you can join whenever. Make sure you all sign the attendance, yeah?
Kita letak nama sendiri. Aku letak nama kau Rofi.
Okay, 10, 9, 8. After 8, 7, 6, 5, 4, 3, 2,
Penal Megali. Apa tu?
Memang
Two.
aku je load.
2, 2.5, and 1, okay. Okay, dah?
Masa awal dapat ni
5,
Damn.
4, 3, 2, 1. Okay, let's start the 97, eh? Okay, kita start, eh? Start, eh? Okay. Just try your best. Don't look at. Try your best. Tengok what's your understanding is. Doesn't matter. Tahu tak tahu.
Ha? Apa ni? Mana aku ingat S1 coordinator.
Dia mana kan ber. Pause. Rafil.
Aku tak tahu.
Doktor sana.
Yang beria, us do better than real men recruit, but okay. 5, 4, 3, 2. Come on, last question. 1. Okay, saya end ya. Okay, all done. Cepat bagi tahu saya. Okay. Let's go with questions first. Alright. Because I've given you a lot of questions on female reproductive system because I've just given you a recorded lecture. So that's why I want you to know I want to know how much you know. Okay? So let me summarize first. So for female reproductive system, that whole recorded lecture too is more than slightly over 1 hour. So just now, I got female reproductive system around less than 30 minutes. So now, kita buat question and answer. So all together, you have 2 hours for female and male reproductive system. Okay? So for female reproductive system, ada 5 groups yang I've introduced. First is yang stimulate ovulation. Ada 1 group of drug je, which is clomiphene. Okay? Then you have uterine relaxer, uterine stimulant. Then you have oral contraceptive, you have hormone replacement therapy. Because the lecture for female reproductive system banyak drugs, that's why I gave you recorded lecture so that you can pause and understand. Okay? So under yang stimulate ovulation, 1 drug je, which is clomiphene. Okay, for uterine relaxant, you relax the uterine. What are the group of drugs that you know of?
Oxytocin.
Boleh remember tak? Something that relaxes your smooth muscle. Magnesium sulfate lagi. Yang beta adrenoceptor tu kan, yang terbutylin salbutamol lagi. Oxytocin antagonist tu atosiban lagi.
Calcium channel blocker.
COX inhibitor, indomethacin.
Ya, indomethacin.
Okay. Kalau the one that is stimulate uterine, oxytocin, that's the first one. Lagi. You have prostaglandin analogs. Lepas tu
Corbopros.
lepas tu anti-progesterone. Yang tu ada satu drug je, which is mifepristone. Okay. Then you have oral contraceptive. Oral contraceptive ada 3. One is combined progesterone only. Lepas tu postcoital. Okay. Hormone replacement therapy is general. Okay. Alright. Itu just an overview so that you tahu how it is being divided. Okay. Oxytocin stimulates the uterus to contract. Oxytocin is the physiological process. Okay. So that means once people go to labor, once a pregnant woman going to labor, the body will release oxytocin. But sometimes oxytocin tak cukup. Okay. Sometimes the fetal distress. So you want to stimulate. So you bagi oxytocin. Alright. Administration of oxytocin can cause water intoxication. True, false? True. Okay, that's one of the side effects. Methyl ergonovin is contraindicated in patients with an eye. Okay, methyl ergonovin. Can you give me example of? Okay, methyl ergonovin, uterine stimulant ke relaxant? Stimulant. Okay, it can cause tetanic contraction. It's very not common to use in clinical settings. Only use masa critical situation for postpartum hemorrhage. Okay, anybody knows what is postpartum hemorrhage? What is postpartum hemorrhage? You tahu tak? When dengan orang tumpah darah. That is postpartum hemorrhage. That means after the fetus dah deliver, sometimes placenta dah remove, tapi dia tak. Tapi you have hemorrhage, severe loss of blood. So what will happen is your body will contract so that they expel the placenta or anything yang ada extra, so that they will stop bleeding. That's what we call postpartum hemorrhage. If you look at this one, prostaglandin analog can also be used for PPH ke?
Yes.
Betul kan? But that one is milder. For methyl ergot alkaloids is more severe. Okay? So what is the side effect of prostaglandin analog? Uterine rupture, because they stimulate contraction. So when you have hyperstimulation, so you have uterine rupture. Okay, dinoproston induces ripening of cervix, true false? Okay, dinoproston under which group? Prostaglandin analog. Can you give me other example of prostaglandin analog? Carbopros, gamipros, all your prosprosto. Okay? Okay, pregnant woman with a seizure and hyperstimulation was administered with drug X. Name drug X. What's the answer? Magnesium sulfate. So the moment they had the seizure, pre-eclampsia, hypertension, you will tend to give magnesium sulfate. Okay? Alright. Menopause cannot be artificially induced. True, false? Why false? Why false? Can you induce menopause? How do you induce menopause? How do you induce menopause? Hysterectomy, removal of the female reproductive organ. Okay, so you reduce production of the hormone. Okay. Prolonged use of high-dose estrogen in postmenopausal. So this is hormone replacement therapy, causes increased risk of what cancer? Endometrial cancer. Okay. You need to understand when you give the drug, what is the risk and what is the risk yang patient tu ada. For example, the patient had breast cancer, okay, can you give hormone replacement therapy? Okay? Or is this the risk of giving hormone replacement therapy itself? Okay? Alright, now we go to male reproductive system. Sildenafil. What's the function of sildenafil? Antagonize guanylate cyclase? No. Enhance the effect of nitric oxide?
Yes.
Increase the formation of dihydrotestosterone?
No.
Okay, so here they enhance the effect of nitric oxide. But what is the specific mechanism of action of sildenafil? It's a what inhibitor? What's the name of the enzyme? Phosphodiesterase 5 inhibitor. So what does it do? It will inhibit the enzyme. So what happens when you inhibit the enzyme? What happens to the concentration of CGMP? Increase. Okay? Okay, now we go to terazosin. Terazosin blocks your zosins. Alpha 1? Okay, now you need to understand whether it is alpha 1A or alpha 1A and alpha 1B.
Alpha 1A and B.
A and B. So why is it important for you to know?
Because A is for smooth muscle.
It will give effect on your blood pressure. So, okay, can you give me an example that of drug which inhibits 5-alpha reductase? 5-alpha reductase. Give me an example of drug.
Finasteride.
Olesteride.
Steroid.
Finasteride, dutasteride. Okay? Last but not least, who's your phase 1 kat Lincoln? Oh my god! Kejap.
Oh my god.
Oh no!
Oh,
No, Data.
Kau jawab apa?
Pause.
kau jawab siapa? Ni.
Data Salih.
Oh, your phase 1 kat Lincoln.
Aku Dr. Hanisa.
What?
Tak
Okay.
tahu.
Who is Dr. Haniza Hassan? Okay, you all jawab siapa?
Dr. Riza.
Dr. Haniza dia tak ada kena-mengena. Dia tak ada dia bukan year 1, year 2, dia bukan phase 1. He just prepares the questions. Okay? So who's Associate Professor Dr. Rosliza?
PDA.
PDA, thank God. Okay. Who is Dr. Farida Idris? Phase 1 coordinator. Why is it important for you to know? Kan this year you all nak ambil Pro kan? Kan? So anything that got to do with Pro 1, the person in charge is Dr. Farida. Okay? Dr. Farida is from Department of Pathology. Okay? Alright. Who's Dr. Siti Salihah?
Our lecturer.
Sorry?
Our lecturer.
Year 1 coordinator.
Yeah.
Okay? Year 1 coordinator Dr. Siti Salihah. Siapa Year 2 coordinator?
Dr. Zul.
Dr.
Anissa.
Please know your lecturers here so that when you have any problem you go to. This is interesting, okay? Anywho, okay. If you have any questions about the reproductive system, let me know. Just bear in mind, this is the only lecture for pharmaco. Okay? I'll stop there, so I hope you understand what I'm trying to say. Okay? I know you know. Okay? So I wish you all the best kalau for your CA tomorrow, yeah?
Yeah.
Okay, good luck. Don't worry, everything will be fine. Kalau if it's not fine, you'll do better for final. Okay? Alright, have a wonderful day. Thank you.
Thank you, Doctor.
Thank you, Doktor. Tak nak dia nak cuti.
Dia pergi mana? Ha? Print? Print? No?
Petang.
Petang. Tengah hari. Dah macam awas sangat kelas habis.
Ya, lepas ni nak tanya Nisa.